Welcome everyone. There is not going to be a lunch break after my presentation, but hopefully you are going to get an insight to the very preterm infants. My name is Vivien Unger. I am a PhD student and also a fourth-year pediatric resident at the Csolnoky Ferenc Hospital in Veszprém. My vision is to provide the highest quality of care to the very preterm infants, and for this my mission is to find the optimal mode of delivery for them and to provide timely and accurate data about peri-viable infants in Hungary. I have two main projects ongoing. The first one is about investigating the relation between the mode of delivery on the mortality and morbidity among extremely and very preterm infants. And the second one is going to be a registry analysis based on the characteristics of peri-viable infants in Hungary. Let me start with the first one. Approximately 15 million babies born prematurely worldwide annually, indicating a global preterm birth rate of about 11%. These preterm babies account for the 35% of neonatal mortality. Very preterm infants who born before the 32nd gestational week are at high risk for death, medical complications, and neurodevelopmental sequelae. The optimal mode of delivery before the 32nd gestational week is still unknown. Despite the benefits regarding the preterm babies, caesarean section rates have been increasing all across the world. Now let me show you a few complications of C-sections and vaginal birth. Delayed neonatal lung liquid absorption, neonatal gut dysbiosis, and higher rates of severe maternal morbidity and subsequent preterm birth rates are non-complications of C-section. Although during vaginal birth, asphyxia may occur, which is a known risk factor for intraventricular hemorrhage. And as we have heard before from Zsuzsa, that intraventricular hemorrhage occurrence among very preterm and extremely preterm babies are very high. Therefore, our aim is to assess the effects of C-section on the mortality and the morbidity rates. To formulate our question, we use the PICO framework. We are investigating preterm babies born before the 32nd gestational week. We are going to compare planned and actual caesarean section and vaginal birth. According to our hypothesis, among very preterm babies, caesarean section decreases the mortality rate and the early morbidities. A systematic search was done in last year, November, resulted in almost 17,000 hits. After the selection process, 16 eligible articles remained. And now let me show you the results. Here we investigated the effects of planned caesarean section and planned vaginal birth on the mortality rates. In this slide and in the upcoming ones, we used odds ratio as a measure of effect. If odds ratio is 1, it means that there is no difference between the effect of the two groups on the mortality rates. If odds ratio is below 1, so the study is situated on the left side of the line, it means that among babies who born by a caesarean section, the mortality rate is smaller than among those who born by a vaginal birth. If it's above 1, so the study is situated on the right side of the line. It means that among babies who are born by a vaginal birth, the odds of death is smaller among those who are born by a vaginal birth. In this case, you can see a very heterogeneous population. Therefore, we have made a subgroup analysis based on the parity and based on the presentation of the baby. So let me show you the results, which are based on the presentation of the babies. Here you can see the effect of the planned caesarean section and planned vaginal birth based on breech and vertex population. In the first 4 studies, we included only the breech studies. As you can see, the odds ratio is 0.56, which means that among babies who are born via caesarean section, the odds of death is almost 50% smaller than among those who are born by a vaginal birth. This is a clinically and a statistically significant result. Meanwhile, in the last 3 studies, we included the vertex very preterm singleton neonates. Among them, there is no clinical and statistically significant difference between the planned vaginal birth, and planned caesarean section group. And now let's see what happens when we analyze separately the twin and the singleton pregnancies. In the first 3 studies, only twin pregnancies were included. Odds ratio is 1.77, which means that among those babies who born by a cesarean section, the odds of death is 77% higher than among those who born by a vaginal birth. This is at the burden of statistical significance, but this is a clinically significant result, although only 3 articles are examined and further analysis as needed. Let me show you one of the early outcomes. Here you can see the occurrence of severe intraventricular hemorrhage and the connection between the planned mode of delivery. Severe intraventricular hemorrhage means grade 3 and grade 4 IVH based on the Papile grading. The odds ratio is 0.98, which might tell us that there is no clinical significant difference between the planned C-section and planned vaginal birth group, but in this case, this was also a heterogeneous population, but we couldn't make a subgroup analysis based on the presentation and based on the parity of the babies. To conclude our strengths and limitations, we involved studies with high number of patients, and we could do a detailed subgroup analysis based on the clinical relevance. Although all of the studies were cohort studies and mostly retrospective ones, and there were some non-standardized reporting. To conclude, for breech babies, for very preterm breech babies, cesarean section decreased the odds of death. For twin pregnancies, vaginal birth might be beneficial in the manner of decreasing the odds of death. This is a surprising and exciting result despite the vertex and the breech babies. And for very preterm vertex babies, vaginal birth might be the option of delivery. Here I am standing at the first project. I'm doing the risk of bias assessment, and I'm planning to finish my article by the mid of May. And let me move on to the second project, which is about the characteristics of periviable infants in Hungary. The definition of the limit of viability is based on the ability of the fetus to survive outside the womb when supported by the most advanced medical care. There has been a change in the limit over time. In the 1980s, it was around the 28th gestational week. Meanwhile, 40 years later, it decreased to the 22nd, 24th gestational week. Although this definition doesn't consider the chances of survival and the survivor's quality of life. To manage these babies properly, hard ethical and medical decisions need to be made. Therefore, we need up-to-date and on data to make these very hard decisions. So our aim is to do a registry analysis based on the Hungarian NICU database, and our question is how did the limit of viability change over time in Hungary? We are planning to analyze a 10-year period, and we hypothesize that over time we could improve in the management of these very tiny babies. To summarize my presentation, you can see here my 2 ongoing projects, both involving very preterm and periviable infants. Let me end my presentation with a quote by Dr. Seuss: "A person is a person, no matter how small." Thank you.
Questions from the audience?
I have a question.
Yes, Zsuzsanna.
You mentioned planned mode of delivery. Could you please explain to us what does it mean?
Yeah, thank you. There are 2 types of analysis in our study. One is the actual mode of delivery, and the other one is the planned mode of delivery. Actual one is the simplest one. So the baby born by vaginal birth, it is going to be included in the vaginal birth group. Meanwhile, the baby born by a C-section, it is going to be included in the C-section group. Although the clinical practice is not always this, because we have to make a decision what to do with that pregnant woman. So can we go for a vaginal birth, or should we do a C-section? Therefore, the planned method was used in our case. So in the beginning of the decision making, we said, okay, it's safe to go for a vaginal birth, but of course, there might some complications happen. For example, abnormal fetal heart rate or some kind of bleeding. Therefore, there need to do an emergency C-section. In the planned mode of deliveries, emergency C-section is going to count in the planned vaginal birth group, because this is much more closer what we can see in everyday practice. We have to make a decision at one point. And of course, you can say that this might lead to some kind of bias, but we think that the analysis of the actual mode of delivery might lead to more bias, and we wanted to rule it out to get a clearer picture of what happens in real life.
You mentioned that in case of twin pregnancies, vaginal birth seems to be more beneficial, and what do you think, why is that?
Well, it was a very exciting and surprising result, as I mentioned. We had to think it through what could be the reason for that, but if you just go through how a vaginal birth managed and how a C-section in case of twin pregnancies, one of the reasons might be that in case of vaginal birth, the adoption of the baby can be betterly managed. I mean, we have heard about delayed cord clamping today, and in case of vaginal birth, it can be performed much easier than in case of a C-section. This might be one reason. The other one that I couldn't show you the forest plot of the sepsis, of the occurrence of sepsis because of the manner of time, but we found that among babies who born via vaginal birth, there seems to be a better rates of, or lower rates of sepsis. So maybe neonatal gut dysbiosis, and then after that neonatal sepsis could be also a reason, but we need to go through the reasons. Thank you.
Congratulations for your presentation, and my question is, among breech babies, you said that the C-section could decrease the mortality, and can you explain why?
Mm-hmm. Thank you. Nowadays, in the guidelines for preterm babies, caesarean section delivery is the option of mode of delivery. So it wasn't a surprising result. The underlying cause might be that during breech birth, the bottom of the baby comes first, which diameter is smaller than the head. So the head needs to come after, and the birth of head might be harder because there is not as big dilation as it should be. And furthermore, the birth of breech babies is really hard. I can say I haven't done it yet, but as I heard, it is not as simple as in case of vaginal birth, and the baby needs to be flopped up to the mother's abdomen, and this neck extension can cause also severe birth injuries. So these are the causes. So birth injuries may occur, and that's why asphyxia and IVH and all the causes. Yes?
Yeah, the last question.
I have a question regarding your method that you said that the planned intervention was taken. I have a similar problem with my thesis. Isn't it easier than to just exclude these patients then? Because it doesn't really show a real effect, or?
We have 16 eligible articles, as I mentioned, and almost half of them is the actual mode. So we have made the analysis for the actual and the planned mode as well, and we are planning to compare them just to tell that maybe the plan, based on the planned analysis, is way better, but we don't want to exclude them.
I understand. And is there any results? Does it influence it or not if you exclude or not these patients? Is there any difference in the outcome?
Actually, in the IVH, it seemed to be better that based on the actual analysis, the occurrence of IVH was smaller among the babies, but we also couldn't make subgroup analysis, so it's not that clinically significant.